Welcome back to the next section of Step 3 of USMLE's preparatory course. This next section is cardiology. The essential features of cardiology start with what the most primordial case in cardiology could be, which is the acute myocardial infarction. Now, the difference between Step 2 and Step 3 in terms of formatting is that 30 to 50% of the questions on Step 2 are questions that say, which of the following are the most likely diagnosis? Now, that same question is only present about 10 or 20% of the time in Step 3. Step 3 is largely an exam in which the diagnosis is handed to you. So therefore, in many of the cases, you will get through the history and physical. You'll feel very good about yourself that you know what the diagnosis is. You're all set to answer, the diagnosis is, and in the very next sentence they say to you, the diagnosis is. They hand you the diagnosis and then say, what do you do about it? So Step 3 of USMLE is a test that has to do with testing and treatment and testing and treatment. It's an extremely clinical examination. You have to think that it's 1915. You're taking the last test you're going to take for your professional life. You're about to be given a license to practice medicine. When all of a sudden you are meant to practice general medicine out in the United States as a GP, what do you need to know? High blood pressure and diabetes, and tobacco smoking and drinking alcohol too much, and heart attacks and depression and general obstetrics and general pediatrics. So we start with the most primordial case in cardiology. I have chest pain. So in this case, we have a 68-year-old man with chest pain, and the same thing here. We know it can't be too much of a diagnostic case because we know that all older guys are meant to die of myocardial infarctions. So we look at chest pain, and we're looking for three basic qualities. Not nausea, not vomiting, not diaphoresis, not short of breath, because no matter what the etiology of the case is, whether it's pericarditis or pneumothorax or pneumonia, all of them can make you short of breath. All of them can give you nausea. All of them can give you diaphoresis. All of them can make you pale. And those things can't be used to answer the question, which of the following is the most likely diagnosis? You look at a case of chest pain, and you say, well, a guy comes with 1 hour of severe substernal chest pain. Does this guy have any risk factors? Yes, I know he is a testicle-possessing person above the age of 50. But does he have any specific risk factors for myocardial infarction? Does he have anything for him? Amongst all the other 38 million people in the United States above the age of 65, half of them being men, of those other 17 million men above the age of 65 in the United States, does this one of those 17 million have any risks for myocardial infarction? I don't see any hyperlipidemia. I don't see any history of coronary disease. I don't see any history of tobacco smoking, hyperlipidemia, diabetes, low HDL, high LDL. Is there any risk factor in this guy at all? And the answer is the history with the father dying at the age of 67 of heart trouble is not a history that's positive for a positive family history. In order to be a positive family history, mom and dad had to have died young. And young means, well, my definition changes all the time. What would you think? Less than 55 is young? I'd go with that. Less than 55 is young. Yes. Anything less than 55 is young. Yes, it changes all the time, the definition, doesn't it? Yes, so the thing is, for it to count as a positive family history, mom and dad had to have had heart attacks young. And young means 55. I mean, 43 is practically pediatrics now, isn't it? So, when you see a certain amount of physical examination like there is here, the amount of physical that you see chosen on each portion of these is meant to simulate when you get this, like on CCS. Chief complaint, string of vital signs, history of present illness. And on CCS, you can choose a certain amount of physical examination, you can write some orders, you can move the clock, or you can change location. like your favorite sushi bar downtown, physical examination on CCS is chosen a la carte. It doesn't actually come, as you might see here in these paragraph forms. You choose it piece by piece. Each one. Do you want to choose just the head and neck exam, just the chest exam, just the cardiovascular, just the abdominal exam? You must click on each one and order it a la carte, like sushi by the roll in a restaurant. And so when you see a certain amount of physical examination with each case, it's saying, for this case, we suggest that you order this amount of physical examination. Now, you'll notice that his head and neck exam is normal. His chest is clear. You'll notice that basically it doesn't show anything. And that's because the most common cardiac examination in a myocardial infarction is a normal examination. The most common chest exam in an MI is a normal exam. But it's not the fact that it's normal here. It's the fact that it could have been abnormal. It could have been abnormal. The chest exam could have shown Ralls. The head and neck exam could have shown jugular venous distension. The cardiac exam could have shown a gallop or a murmur. It could have been abnormal. So just because it's normal does not mean it's wrong. You choose piece by piece, clicking on each piece of physical examination on CCS, choosing it piece by piece, not based on what is actually abnormal, but based on what could be abnormal, what might be, possibly be, could be. You look at this chief complaint, history of present illness and string of vital signs, and you choose this amount of physical examination based on what could be abnormal. Should we get a rectal? And you say, always. And the answer is, are there any rectal abnormalities in a myocardial infarction? Think. I don't know what that means. And the answer is no. There are no rectal abnormalities. There are no lymph node abnormalities. There are no findings on skin with a myocardial infarction. So you look at each piece and you say, what could be abnormal? So you can't go through and say, how much physical should I choose? Well, what's the case? I can't tell you. Well, then I can't tell you. But no, I want to know how much physical to choose. I can't tell you how much physical to choose. Well, I want to know for every case how much physical. Well, what's the case? What's the detail? I can't tell you. Well, I can't tell you. Well, no, you know, you're just not telling me. You know, and you're withholding it from me. Conrad Fisher withholds nothing. We all know that. But you have to say, what is the case? In otitis media, don't answer rectal. In rectal bleeding, don't look in their ear. Okay? It depends. It depends on the case. Now that means, from the chief complaint and the history of present illness and string of vital signs, that means that from this, you have to have decided what the diagnosis is just based on these three things. So based on these three things, it will help you to know how much physical to choose. What might be abnormal. Now, if I went through and I said, in this case, choose head, neck, heart, and lung exam, then the circumstances change and you are wrong. So if I give you something specific to a circumstance, the circumstances changes, you're wrong. But if you memorize the question, then no matter what the circumstances are, you will always be right. The question is, what might be abnormal based on this history of present illness? Therefore, you will always be right, because the question never varies, even though the circumstances do. So we look at this case, and we say, we've got an older guy who's got chest pain, who's got no cardiac history. We got an older guy who's got chest pain, who's got no cardiac history, and a normal physical examination. It's extremely unlikely that they ask you the diagnosis in this case. Even my mother could get the diagnosis in this case. because it's an older guy with exertional chest pain. Also, they're telling you right here, the pain is not reproduced with palpation. The pain does not change with position. The pain is not pleuritic, does not change with position, palpation, and respiration. Position, palpation, and respiration. Position, palpation, and respiration. And if it changes with any one of those things, position, palpation, or respiration, then it is not a myocardial infarction. And you say, but listen, in life, sometimes it can be. Sometimes you can have a heart attack and it's tender. Ow, that hurts, Daddy. Yes, it's true. Sometimes, yes. 4% of the time. 4% of the time in life, in the emergency department, you can have a myocardial infarction, and 4% of the time, there's tenderness. 4% of the time, hi. It changes with respiration. 4% of the time, it changes with bodily position. But on the boards, if they tell you positional, pleuritic, or tender, they're telling you it's not a myocardial infarction in terms of all the chest pain cases. You look at the differential diagnosis section, and that differential diagnosis section says, well, these are all the things that could be there. They could be the wrong answers. It's the right answer as well as what the other possible wrong answers are. That's what the differential is about. The differential is about how to answer the question, which of the following is the most likely diagnosis? Yes, one of those is the right answer, but what are the wrong answers going to be? So they ask you the question very rarely, which of the following is the most likely diagnosis? And instead they simply say, what's the best initial diagnostic test? But not in this case. They won't ask you what the best initial diagnostic case is in a case of this straightforward simplicity. So they say the EKG shows ST segment elevation in V2 to V4. ST segment elevation in V2 to V4. They hand you ST segment elevation in V2 to V4, and they say, what is the next best step in the management? What you gonna do now, Doc? What's now? Treat. Well, let's see. Answer A, treat. Answer B, don't treat. Answer C, consult. Answer D, euthanasia. I don't think so. Could you be a little bit more specific? What do you like at that restaurant? What would you like tonight? Food. I want to eat. Can you narrow it down, honey? Enzymes. Which enzyme? Papain? Meat tenderizer? Which enzyme? LDH, troponin, CPKMB, myoglobin, or urinary beta HCG? Be a little more specific. Enzymes will be in the answer. LDH will be in the answer. Troponins will be in the answer. CPKMB will be in the answer. Thrombolytics will be in the answer. Beta blockers, angioplasty, aspirin, nitrates, beta blockers, ACE inhibitors, and calcium blockers. And it's not enough to know that you use those things. It's not enough to know that you use those. But what's first? In this case, aspirin first or oxygen? Oxygen is the most common wrong answer. Aspirin. Good. That's good. Instantly change your answer with no sense of facial expression or moral compunction. Okay, you remind me of somebody I voted for in the last election. Okay. Okay, so this guy. Enzymes will not be correct. Enzymes will not be correct in this patient. Why not? Why will enzymes not be correct in this patient? Because there's not enough time. They don't begin to elevate for 4 to 6 hours. 4 to 6 hours. They don't begin to elevate. Either the CKMB or the troponin don't even begin to elevate for 4 to 6 hours. Either one. So this guy comes in with 1 hour of pain, and it means that his enzymes won't even begin to elevate. for another few hours. So enzymes in this case is wrong. The other thing is that in this case they're giving you chest pain. They're giving you ST segment elevation. They're giving you the old guy with exertional chest pain with ST segment elevation. They're handing you the diagnosis and saying what you're going to do about it now. And it's always treatment more important than testing. And the answer is that this guy gets aspirin because oxygen, although it's a great thing to do, doesn't lower mortality. Besides aspirin, which other medications will lower mortality in this man? Thrombolytics will lower mortality. Which thrombolytic will lower mortality in this man? Any of them or all of them? Oh, all of them, not any of them. It's the same thing. So, any and all thrombolytics will lower the mortality in this man. Any of them will lower it. Any of them will lower it. Thrombolytics will lower it, okay? Up to how long after the start of the chest pain? Anybody less than how many hours after the start of chest pain? 12 hours. Anybody at less than 12 hours after the onset of that chest pain will be benefiting from the thrombolytics, because you can benefit, meaning that you can show a mortality benefit even up to 12 hours. So the numbers are not based on my personal opinion. They're not based on my personal practice habits. They're not based on what the Conrad Fisher medical licensure exam should be. But rather, what does the American College of Cardiology tell us? It says, hey, 12 hours. Why? Because there's still a mortality benefit up to 12 hours. You can make people live longer. What other drugs will lower mortality for sure in this man? Beta blockers will lower mortality for sure in this guy, and everybody should get a beta blocker. Everybody should get a beta blocker. Everybody should get aspirin and thrombolytics. What else will lower mortality for sure? ACE inhibitor will not lower mortality for sure. ACE inhibitor will only lower mortality if the patient has congestive heart failure. Only if the patient has congestive heart failure will there be a demonstrated decrease in mortality, is if there's congestive heart failure. And how are you going to define congestive heart failure? Do we all have the same definition of that? Being very juicy. I'm feeling very juicy this evening. I must have congestive failure. What do you mean by congestive failure? An erection fraction less than 40%. Yes. Or Ralls. Or a gallop. But the main one is an ejection fraction less than 40%. An ejection fraction less than 40%. So ACE inhibitors will only lower mortality if the ejection fraction is less than 40%. So, everybody gets these drugs. Now, if this is single best answer questions, 80% of the test is single best answer questions. If this is single best answer questions, then you're going to choose aspirin. Now, if this is CCS, you mean we have to prepare for both single best and CCS at the same time? Uh-huh. Uh-huh. If this is CCS, you're going to answer troponins and EKG and thrombolytics and beta blockers and aspirin and oxygen and nitrites and morphine, all at the same time. If this is single best answer question, you're going to answer aspirin first. If this is a CCS question where you can answer 1,000 tests and treatments at the same time, then you will do all of them at the same time. Aspirin, thrombolytics, beta blockers, oxygen, nitrates, morphine, CKMBs, and troponins. Repeat the EKG and give them a bill under their door tomorrow morning at 4 a.m. like early checkout at the Holiday Inn, all at the same time. If it's CCS. So you have to do both things. You'll have to look at each of these cases and simultaneously prepare for the same, both questions from the same case. It's one single best answer and one CCS answer. You notice the calcium blockers are not there. Why not? Why are calcium blockers not in the answer here? Because they cause mortality? Or they lower mortality? Well, life causes mortality in a certain way, right? Terminal disease, just like love. So the thing is, they don't lower mortality. Calcium blockers don't lower mortality. What is the predominant determinant of how much oxygen your heart consumes? What's the predominant determinant? Chronotropic, dromotropic, inotropic. Chrono, rate. Dromo, conduction. Ino, contractility. How much are you squeezing? Rate, conduction, or contractility. The major determinant of myocardial oxygen consumption is rate. Frequency. It's actually not contractility. The contractility idea is a flawed idea. It's a flawed idea. The idea that how much of contractility, how forcefully it contracts, is the major determinant of oxygen consumption. It's sort of like the same flawed approach as men cleaning the house. The male approach is, let's clean the house once really, really, really well, and then we never have to clean it again. Whereas we know that really what makes the difference is regular frequency of cleaning is much more important than cleaning the house once or twice really, really well. So the major determinant of cardiac myocardial oxygen consumption is frequency, is heart rate. Beta blockers clearly lower heart rate. How much do calcium blockers lower heart rate? Oh, no. When you're in sinus, not when you're in fibrillation. How much do calcium blockers lower heart rate? No, not in fibrillation and not in SVT, but when you're in sinus. How much of an effect on your SA node is there of the calcium blockers? And the answer is not very much, almost nothing. Almost no effect. So beta blockers slow your heart rate. They decrease the heart rate and they don't make you consume much oxygen. They decrease the force of contraction, but the more important thing is just decreasing the frequency of contraction is the major determinant of myocardial oxygen consumption, not the force of contraction. And that is probably why calcium blockers don't lower mortality as much as you'd like to. ACE inhibitors lower it if there is congestive heart failure. So let's look at this case. Let's change the case. Change the case a little bit. And we say that he is a 68-year-old guy who comes to the emergency department while he was helping his son move furniture into his apartment. And he comes in and he's got the ST segment elevation in V2 to V4. And he's got a subdural hematoma and an epidural hematoma, a subarachnoid hemorrhage, melena, a rupturing abdominal aortic aneurysm, and he's having his period. Everything else is the same. What you going to do about it? ST segment elevation. Within 1 hour of having chest pain, 1 hour, and he's sitting here going, he's got Levine's sign. What's Levine's sign? You'll love Levine's sign. Levine's sign? Oi, does my chest hurt? Yeah, that's legitimate. Oi, does my chest hurt? Levine's sign. You can't make up stuff like that, you know. And I try. What would you do? This history, this physical, this history, this physical. What is the next best step in the management of this patient? Is aspirin. Don't give aspirin to people with subdurals and epidurals. It's no good. Because then their right cerebral hemisphere becomes their left cerebral hemisphere. Don't give aspirin to people with subdurals and epidurals. Because then you come to do a rectal exam and say, nice smooth prostate. And he says, that's not my prostate. It's my pons. Don't give aspirin to them. Nitrates. Next. No. Angioplasty. Angioplasty? The next thing you want to do is put 3 feet of plastic catheter in someone's groin? Why is angioplasty next? Because you can't give thrombolytics and it lowers mortality. You can't give thrombolytics and it lowers mortality. I've got an indication for thrombolytics, but I can't give thrombolytics. I want to give thrombolytics, but I can't give thrombolytics because they're going to bleed to death. Angioplasty. Angioplasty. CCS, angioplasty, and beta blockers, and nitrates, and oxygen. Single best answer, angioplasty. It depends. It depends. It depends on the case. What's the difference between the troponins and CPK-MBs? What's the single biggest point of difference between troponins and CPK-MBs? Specificity. Specificity. It's specificity. The single biggest difference is not how fast they rise. The single biggest difference is specificity. For instance, does your uterus make any troponins?
Yes.
Your uterus makes troponins. And that is the most common wrong answer. Your uterus can still make some CPK-MBs, but your uterus does not make troponins. So that's the biggest difference. Smooth muscle does not make troponin. Only the heart makes troponin. Smooth muscle can still make some CPK-MB. Smooth muscle can still make CPK-MB, but smooth muscle outside the heart does not make troponin. So CPK-MBs are very, very specific, but troponins are the most specific. And that is the management of this patient. Let's go on to the next case. Patient's blood pressure. Wow. You are called because a 68-year-old man got admitted through your intensive care unit. Well, now you have your own intensive care unit. Isn't that exciting? Well, it looks like the same guy we had before. Except this guy has an inferior myocardial infarction, and the first guy had an anterior myocardial infarction. This one's got an inferior myocardial infarction. And you're called by the nurse because the guy's got low blood pressure. He's got this low blood pressure. He's got this big systolic murmur. His abdomen is benign. Low blood pressure. And the question is really, what are the complications of a myocardial infarction? What can happen to him that results in a sudden drop in blood pressure? And that's what all these things are here in the differential. In the differential is, what are all the things that can happen post-MI that result in a sudden drop in the blood pressure? And that's the point here. And that is the point. Now, all of these are complications of myocardial infarction. But which one of these will cause a low blood pressure? Which one? Think, 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 think. Which one will cause a low blood pressure is all of them. Yes, all of them, every single one. Which one of these is a complication of a myocardial infarction? All of them. Which complication causes low blood pressure? All of them. Could this patient have a ventricular septal defect? Well, he could, but he can't. Is it possible for this to be valve rupture? He's got that murmur. He's had an MI. Is it possible to be a valve rupture? You'd like it to be possible. I'd like it to be possible too. And I'd like a lot of things. But it's impossible for this to be valve rupture. It's impossible for this to be chordae tympani rupture. It's impossible for this to be VTAC. Why can't this be VTAC? Why can't it? It's impossible. Why? Why can't it be ventricular tachycardia? Actually, we'll do this. Why can't it be ventricular tachycardia? Because he has an inferior wall MI. No. Why can't this be ventricular tachycardia? Because he's hypotensive. No. There's an experiment. Why can't this be ventricular tachycardia? You're drawing a blank. You're mystified by my sudden appearance of beauty. You're wondering whether I should have hair implants or try the minoxidil. I feel the same way. Why can't this be ventricular tachycardia? Because he has bradycardia. Oh. I try. Isn't it interesting? It's a little byproduct of medical education. Can't be ventricular tachycardia when you have slow heart rate. It can't be ventricular tachycardia. It can't be any of these: septal defect, valve rupture, tachycardia. It can't be papillary muscle rupture. It can't be cardiogenic shock, because every single one of those causes a tachycardia. The fundamental issue in this patient is the pulse. The fundamental issue is every single one of those causes a rapid heart rate, with the exception of heart block and sinus bradycardia. And how do you know this isn't sinus bradycardia? How do you know it isn't sinus bradycardia? I know you're afraid to have your mistakes immortalized. It's easier. Just immortalize them. God knows I do. Okay? So, the answer is it can't be sinus bradycardia, because this is the original case, by the way. This case was originally published in 1826 in the Medical Journal of Dublin. It was published in 1826 and 1848. The details about the ICU have been added, but the details of the history and physical are largely the same from 150 and 175 years ago. How did two Irish guys named Stokes and Adams describe this problem in between pints of Guinness 175 years ago at the University of Dublin, and published in the Irish Medical Journal, actually? The difference between this and sinus bradycardia is that this patient has Cannon A waves. This patient has Cannon A waves. And Cannon A waves in the neck are pulsatile waves in the neck consistent with atrial systole against a closed tricuspid valve. Normally, atrial systole against a closed tricuspid valve. Normally, the atrium contracts, and blood should go forward into the ventricle. But now the atrium contracts, but the tricuspid valve is closed. So where's the blood going to go? It can't go forward into the right ventricle because it's got this closed tricuspid valve. So it goes backwards up into the hemorrhoids. No. Cremasteric reflex. No. It goes backwards into the neck veins. Normally the atrium contracts. Blood goes forward into the ventricle. But now the tricuspid is closed. Atrium contracts. Closed tricuspid valve. Goes up into the neck veins. Like a cannon shot. Like a cannon shot. Atrial systole against a closed tricuspid valve. Cannon shot in the neck. This is third-degree complete heart block. Third-degree heart block. Third-degree heart block in electrocardiographic finding. Atrial ventricular dissociation. P waves with no relationship to QRS complexes. P waves with no relationship to QRS complexes. How is it that two Irish guys in between pints of Guinness 175 years ago, 75 full years before Einthoven invents the EKG. Einthoven gets the 1908 Nobel Prize for developing the electrocardiogram. And these guys described third-degree AV block before the invention of the EKG that you need to document it. Because last I noticed, you can't go, ooh, I feel the P wave. I'm feeling your QRS. I feel it. How is it that these guys could describe third-degree AV block without an EKG? I love it when you have that look in your face. He's got that look. You can't see it in the camera. It's like this. There is nothing more beautiful in the world than watching you think. How did he describe third-degree AV block without an EKG? Canon A waves, bradycardia, and dizziness or low blood pressure. Which one? No, because there was no blood pressure cuff. There's no such thing as a blood pressure cuff. When Stokes and Adams lived, there was no such thing as a blood pressure cuff. When Stokes and Adams lived, the most advanced cardiac instrument there was the stethoscope. It had just been invented by Laennec across the river called the English Channel a few years earlier in France. The most advanced weapon they had was a stethoscope. The stethoscope was what you and I would think of as an MRI or a PET scanner. Hey, did you hear they just had the stethoscope installed at the medical school? Oh, that's so cool. Can we overutilize it? So the issue is that you have people called for lightheadedness and syncope, passing out lightheadedness, syncope, and seizures, Canon A waves, and bradycardia. Now, only 10 or 20% of the questions on step 3 are, which of the following is the most likely diagnosis questions? And this would be a perfect case for that question. Because of all the things you see here, only one of them can be third-degree AV block. It would be the perfect question. They all are complications of MI. They all cause low blood pressure. Only 2 of them, or 3 of them, cause bradycardia, and only 1 will cause bradycardia and Canon A waves, complete heart block. So now I've handed you the diagnosis, and I've made it too easy. Now it's all done, and I tell you it's a guy with an MI who has low blood pressure and bradycardia and Canon A waves, and I've handed it to you, and it's too easy, and you don't need me now. There's only one other little question, but it's too easy, and then you won't need me at all. I tell you he's got third-degree complete heart block, AV dissociation. Third-degree AV heart block. What's the best initial therapy? What would you do first in the management, treatment? What would you do first in the treatment of a patient with complete heart block like this? What kind of pacemaker? A transvenous or a transthoracic? Huh? Out of it? Transthoracic? The cutaneous pacemaker. Come on, show some facial expression. This will help you at home. Transthoracic is the best initial therapy. So we put on the transthoracic pacer, the transcutaneous pacer, and it sends electrical impulses through your chest, through your back, and it contracts all the muscles of your pectorals and your back muscles. It goes through into the heart. Contract, 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 contract. Best initial therapy. And you're sitting here, and the patient's contracting, 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 contracting. And you go, this is better than a transvenous pacer because I didn't have to perforate you. But you see, the electrical impulses can't distinguish between your pectorals and your back muscles and your heart. So it has to contract everything on the way through. So you come by later on and you say to the patient, how's it going with that transcutaneous pacer? Feeling better? And the patient says, well, actually, yes, because my heart rate has come up 30 points, my blood pressure has come up 30 points, and my IQ has come up 30 points, all over the last 15 minutes since you've had on this pacemaker. And you say, well, you know, we could have given you a little milligram of intravenous atropine. It would take about 2 minutes. It has no complications. It's effective in most people, and basically could have sped your heart rate up with no complications. 1 minute of injection with 0 problems. We could have done that instead, you know, instead of the transcutaneous pacer. And the patient says, well, yeah, that's true, but, you know, this pacemaker has been pretty effective, and my heart rate is up, and my blood pressure is up, and my IQ is up, and, you know, besides that, you know, I've increased a full cup size in the last 2 hours. So overall, I think it's better. The best initial therapy in the management of complete heart block that's symptomatic is, you're still stuck on that transcutaneous pacer now, aren't you? 2 transcutaneous pacers. 1 for each side. And the answer is atropine. But the most common wrong answer is transcutaneous pacer. The most common wrong answer is transcutaneous pacer. The transcutaneous pacer cannot distinguish between your pectorals, your back muscles, your heart, your intercostals, and it contracts all of them. And it's very nice if the atropine doesn't work. Atropine and pacemaker. Atropine then pacemaker. He does need a pacemaker. But I didn't say what is the most effective. I said what's the best initial. I said what's the best initial? It's atropine. So this patient, bradycardia, Canon waves, hypotension. If there's hypotension, atropine. And then a pacemaker. You only use dopamine if the patient can't raise their blood pressure with atropine and the pacemaker alone. Dopamine is only used for those whose blood pressure will not respond to the initial use of atropine and the pacemaker. I've given him the atropine, I give him some more atropine, and then I gave him a pacemaker, and their blood pressure is still low. That's lousy. Fluids and dopamine. Fluids and dopamine, fluids and dopamine. But only if the atropine in the pacemaker has not been effective. Next case. Case number 3. I have a funny sensation in my chest. I have a funny sensation in my chest. A 72-year-old man comes in with chest discomfort for less than an hour. Chest discomfort. I don't know what that means, chest discomfort. Well, he has a history of arrhythmia. Well, whatever. I don't know what that means either. Now, this is a different type of case from the one we just did. The last case can only be one thing. Only one thing gives bradycardia, Canon waves, and that's complete heart block. Now, in this case, this is pretty non-specific. He could have ischemia. He could have an arrhythmia. He feels something strange and tingly and uncomfortable inside his chest. He could just be in love. But there's only one clue in this case that gives at least a hint to the group of diagnoses. One thing in the case that tells you not the precise diagnosis, but what group of diagnosis, what one thing is in the case that tells you it's got to be an arrhythmia. What tells you it has to be an arrhythmia? Heart rate. Ah, Mr. Pacemaker Man redeems himself. Alhamdulillah. Okay. So the thing is that heart rate tells you this has to be an arrhythmia. Heart rate tells you that this has to be an arrhythmia. Heart rate tells you it has to be an arrhythmia. The patient has a heart rate of 210. 210. What is your maximum heart rate? What's your maximum heart rate? Inquiring minds want to know. What's your maximum heart rate? You're like, I never thought about it, but I haven't been there lately. Your maximum heart rate is 210 minus your age. 220 minus your age. Now, I didn't learn that in medical school, but I did definitely learn it in aerobics classes. Leg lifts, girls. Leg lifts, 6-second pulse. 220 minus your age on the charts for the aerobics classes, which means that except if this guy is a neonate, with the exception of being a neonate, you don't get heart rates of 210. 220 minus your age. That means this guy, if he goes above 140 or 150, he's got an arrhythmia. If he goes above 150, it has to be an arrhythmia. Now, it can't tell us which arrhythmia, but it tells us there's an arrhythmia. A sinus rhythm does not go above 220 minus your age. Actually, to even get within 85 to 90% of this, 85% of that would be called a maximal stress test. Just to get within 85% of that would be a maximal stress test. You can't get up that high without an arrhythmia. VTAC, SVT, atrial flutter, atrial fibrillation. Which one? VTAC, SVT, atrial flutter, atrial fibrillation, and the answer is yes. VTAC, atrial flutter, atrial fibrillation, supraventricular tachycardia, or Wolff-Parkinson-White. Which one? Yes. Could this be ventricular fibrillation? Is it possible? to be VFib? Is it possible? Hello? Well, it could be, except for one thing. He's got something on physical that makes it impossible to be VFib. What on physical makes it impossible for this to be VFib? He's alive. The thing that makes this impossible to be ventricular fibrillation is that on physical examination he was found to be alive. The chief complaint with VFib is, you would look for a chief complaint that says, I am feeling very dead today. I woke up feeling mighty dead today. Then it could be ventricular fibrillation or asystole because you're feeling mighty dead. Universal fibrillatory sign. The ventricle beats like this. The ventricle's having a seizure. That does not organized way, not loop, 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 does not organized bring out the blood out of your heart. It should be an organized loop, loop, instead of you're dead, as opposed to asystole. So that's the two things it can't be. VTach, yes. SVT, yes. Multifocal atrial tachycardia, yes. Supraventricular tachycardia, yes. You can't distinguish them. You look at this patient, you say, the only reason I even know this has to be an arrhythmia is because I can't get a heart rate up to 210 without an arrhythmia. Which arrhythmia? All I can tell you is it's not VFib and not asystole. If this was asystole, the next best step in the management of this patient would be, what would you do first if this was asystole? If this was asystole, the next best step in the management of this patient would be atropine, epinephrine, defibrillation, autopsy. Go through his pocket looking for loose change. Asystole, atropine, epi, defibrillation, cardioversion. Cardioversion is the most common wrong answer. Epinephrine and atropine, and epinephrine, atropine, and epinephrine, atropine, and epinephrine, atropine. Epinephrine, atropine, and epinephrine, atropine, and epinephrine, atropine until you give them 3 times. After that, what do? Asystole, epinephrine, atropine, and then they are all the way dead. Like in The Princess Bride. He'd just be mostly dead. But if you give epinephrine, atropine, and it doesn't respond, then he's all the way dead. Okay. So, this guy is too lively to have asystole. Okay. It could be SVT, AFib. But in this case, it's ventricular tachycardia. Now you may notice that I'm pulling down the case and not revealing it until we get there. And those of you out in videotape land, cover up there, cover up. Don't reveal all the answers right away. You don't do question books with the right answer circled, do you? You don't do question books with the right answer circled, do you? I hope not. The same way, you've got to reveal this. You've got to practice. This history, this physical. This history, how much physical would I get? This history, how much physical would I get? This history, this physical, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate test? What is the best initial therapy? VTach, this history, this physical. History and physical, and then this labs. This history, this physical, what is the next best step in the management of this patient? Lidocaine, amiodarone, procainamide, Issey-Miyake, Chanel, cardioversion. Well, we do know hysterosalpingogram will not be an answer, right? It comes down to this. This guy, as he is now, shock or amiodarone lidocaine? Shock or lidocaine? Shock. This guy, it's ventricular tachycardia. And on ventricular tachycardia, it comes down to the management of this. Is he stable or is he unstable? Is he stable or is he unstable? Now, if he's stable, then you could answer either amiodarone or lidocaine. Both of those are pretty good. And if he's unstable, then you do electrolysis on his chest. Shock, shock, shock. Give him a waxing, he'll never forget. So that means we all have to have the same definition of being unstable, don't you? We all do. We all have to have the same definition of being unstable. We all have to have the same definition of being unstable. So what does unstable mean to you? Yes, low blood pressure. But which low blood pressure? Systolic or diastolic? Or mean? Low blood pressure. We can all agree on that. What could be easier? What could be more simple? What could be more straightforward? Low blood pressure. But which one? Systolic. You live off your systolic. What could be easier? What could be more straightforward? What could be more clear? Low systolic. Low systolic. Very easy. Low systolic. Low systolic. I agree. Low systolic. Low systolic. Low systolic. Low systolic. How low? 110? 100? 90? 80? 70? Systolic blood pressure less than 90. Systolic blood pressure less than 90. Systolic blood pressure less than 90 means you're unstable. You've got to think like this. Compassion is a highly evolved spiritual condition. To suffer with someone, to undergo with. It's a highly evolved spiritual condition. So until you can get there, try extending your narcissism. I can't really feel what that guy feels, but I know what I would like. And I'll tell you, I wouldn't like to be cardioverted unless it meant the alternative was death. Because if you're at home right now, it means you've stolen this tape. But if you go home after this, what can you do in the privacy of your own home to simulate cardioversion? What are you wearing? What can you do to simulate cardioversion at home? No, it's not putting your finger in an electrical socket. That's usually the most common wrong answer. No, cardioversion can be simulated by being at home, ironing. Oh, whoa. Take the iron? No, not taking an iron and putting it on your chest. Oh, I thought you said cardioversion feels like taking an iron and putting it on your chest. Absolutely not. Doesn't feel like taking an iron and putting it on your chest? No. What does it feel like? Taking 2 irons and putting them on your chest. Hey, whoa. Extend your narcissism. Now, what's the answer? If it feels like putting 2 hot irons on your chest, then we give the electrical jelly to increase conduction into the heart and less burn. More conduction, less of burning. More conduction, less burning. When would you let this be done to you? Hypotension, I agree. But when would you let it be done to you? How about sweating? You're sweaty. Shock you. No. You're awfully very sweaty. No. I'm sweating. Don't burn me. No. Pale. Are you pale? No, just the way I am. Right. Pale. Who could agree? Pale. Who's pale, not pale? Sweating. Paler. Cold and clammy extremities. Who could tell these things? Too subjective. Too much like wine tasting. Hypotension. Systolic less than 90. Chest pain. The alternative is I'm going to have a myocardial infarction. When you see these things in the case, they become the most important thing in the case. Chest pain, or hypotension, or shortness of breath from congestive failure. I can't get the blood pumped out of my lungs. Not pallor, not sweating, not a sense of impending doom, not palpitations. My mother spent 23 years like that. It didn't kill her. So palpitation is not hemodynamic instability. Palpitations, half the time, don't even have a cardiac etiology. You have to have something that means you're going to die. I got chest pain. I'm going to have an MI. I'm going to die. Okay, I'll take the burn. Hypotension. I'm going to die. I'll take the burn. Shortness of breath. I'm going to die. I'll take the burn. And chest pain, shortness of breath, hypotension, and no matter what you see in that case, these are the most important things. No matter what is there. What do you see? I see diaphoresis. I see sweating. I see pallor. What do you see? I see my arm. I see the bird. I see you, my teacher. What do you see, Arjuna? I see chest pain, shortness of breath, hypotension, and confusion. Hemodynamically related confusion. Confusion. And then somebody always comes up and says, but people with Alzheimer's, they're confused. Would you shock them? No. But you said confusion. Hemodynamically related confusion. Oh. Oh. Anything else? Any one of these? Anything else? Would you use urine output? How about urine output? Can you use urine output to shock you? Huh? 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 Urine output? Yeah? No? No? Urine output? Are you peeing right now? Are you urinating right now? Check. Well, we're all intermittently anuric, aren't we? We're all anuric. And you say, so you can't use urine output to tell you whether or not to shock someone. Now, generally speaking, urine output is a good thing to use, generally speaking. Urine output, renal function goes down with decreased perfusion, and generally it's a good idea. But you can't tell, because right now everybody's intermittently oliguric. And you say, yes, 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 but we could intubate the penis. We could intubate the penis and see right now whether or not, with a catheter, whether or not he's making urine. Catheterize the bladder and see, but still it takes hours. It still takes hours to determine. It still takes hours to determine urine output. So therefore you can't use it. It can't be like this. The guy has got VTAC. Yeah, okay, let's wait a couple hours and see what the urine output is. 20 minutes later. 20 minutes later. You need something you can tell right now, right now, right now, right now. Chest pain, hypotension, shortness of breath, confusion. When you see any one of the four of those things in a case, it's the most important thing. Forget about everything. Like the Jedi, right? Forget about those other things. Chest pain, shortness of breath, hypotension, confusion. Chest pain, shortness of breath, hypotension, confusion. Yes. Chest pain, shortness of breath, hypotension, confusion. Gives you power over the weak-minded. Chest pain, shortness... Oh, not me. Because you're going to see sweating. You're going to see GI bleeding. The person's GI bleeding. Are they unstable? Well, I don't know. They got melanic or they got a red blood... No. Do they have chest pain, shortness of breath, hypotension, confusion? The person has sepsis. They're septic. Oh, my goodness. Well, they got this, and they got that, and they got this, and they got a white count of this, and they've got an acidosis. Yes. But do they have chest pain, shortness of breath, hypotension, confusion? Sepsis, GI bleeding, non-ketotic hyperosmolar coma, DKA, all of them. The most important thing in those cases, hemodynamic instability. Chest pain, shortness of breath, hypotension, confusion. AFib, any one of those? Shock. SVT, any one of those? Shock. Multifocal atrial tachycardia, VTAC, atrial flutter. Whichever one you see, it means apply electricity here. And that's how you know. Drug versus electricity. Your level of question on step 3 will not be, you know what, Conrad, I've been really trying to think about whether to use radiofrequency catheter ablation in this person or electrophysiologic mapping versus ibutylide infusion or dofetilide infusion. Can you help me out with that? Your level of question on step 3 is like this. I'm asleep at my home in my palatial house in Englewood, New Jersey. I'm not getting up. It's 3 o'clock in the morning. Can you keep him alive for 1 hour? First hour of management. Keep him alive for 1 hour. That's your level of question for step 3. And they're going to ask you drug versus shock. Chest pain, shortness of breath, hypotension, confusion. See you in the next case.